Hi, welcome to another lecture from APP to APP. So glad you could be here. Today we're going to be doing a rapid fire allergy update. So a short video, about 30 minutes total, that covers what's new in allergy and just how you can help your patients do better this allergy season. My name is Brian Bizik, and I'm going to be going through this with you. My contact information is up there on the screen. This is intended for medical providers in the US or abroad. And so anyway, we're always here to help and happy to answer questions, in this case, about allergies, seasonal allergies and what's out there, whatever the counter products worked. There's just a lot going on. It's getting into the warmer months right now when we're recording this. And so hopefully this is helpful for you and your patients. That's some of the conflicts I have. Nothing really with this particular set of slides, but that's there just in case you want to see that. All right, what are we going to do? We're going to do a quick overview of allergy. Why on earth do we have them? Which is another whole great video I would love to do, but not going to do that one. Just why do we have eosinophils? But what's going on with allergies? Just a review of that. Just a little bit about allergy testing and what that's all about and when it might be helpful to send your patients that way. What's new for the prevention and treatment of food allergies? That's not really the focus of my talk, but I want to throw in just a couple of points about the prevention of food allergies. And this, again, this is more of an environmental allergy talk and using antihistamines. That's the goal of this quick rapid fire allergy. But if you're not familiar with early introduction or what we can do with peanut desensitization and other nuts, I did want to share it because it's so critical for our patients. And just tons of tips and tricks. I'm going to go through each part of the body, and we're going to talk about how to treat the allergy symptoms that patients may have there. All right. And just talk about that burden and how we can help them. So going to get there. Allergies, all kinds of environmental insults to us. We've got plants and pollen, latex, bee stings, venom allergies, hymenoptera, yellow jackets, and then obviously there's foods. Just a lot of things that our body can say, hey, this isn't okay, right? These are harmless things generally, but our body thinks that they're very, very harmful. So that's how we react. And just why do we have it? So it's the body trying to protect us. If you think about it, the sense that our immune system has is, hey, this cat dander is going to kill you. So I will help you. And if you go over to grandma's house and she's got 3 cats, I know I will save you and I'll make you a ton of snot and I will trap that and I'll trap that animal dander in your nose and it'll come out, or I'll make mucus in the GI tract, or I'll send blood to the skin so it can get rid of whatever's going on and you'll get hives. That's what's going on. In the eyes, you can see it. The conjunctiva of the eyes gets inflamed. That's allergic conjunctivitis. It's your body trying to protect you. If there's cat dander on your eyes, I'll make tears and you'll have watery eyes and the nerves will go crazy so they itch. In the nose, we've got swollen turbinates. That's allergic rhinitis. In the esophagus, we can get eosinophilic esophagitis. Same thing. It's an immune system that's reacting to something that's harmless, but the body thinks it's harmful. There's hives. Oh, don't those look itchy? There's hives there. And so that's allergic urticaria. This is eczema, right? This is severe atopic dermatitis. So it's a skin barrier breakdown and allergens and irritants get in the skin. And over time, the body's trying to protect you. So it's going to make a ton of skin, make it very thickened. And so this looks very itchy too. So all we're talking about is atopy or allergic, or the predisposition to have allergies. Allergic rhinitis, asthma, atopic dermatitis, these are all types of atopy or, atopic patients. And this is the world of allergy. Lots of hypersensitivity reaction. Well, there's 4 types, but all of these involve the immune system overreacting something that is not harmful, but the body perceives as harmful. We see it. The response is that this is harmful. The immune system takes steps to protect us. But in the case of allergies, these are steps that we don't really need, because despite the fact that the cat dander at grandma's house is thick, that cat dander in and of itself isn't going to hurt us. But our immune system doesn't know that. Lots of risk factors, heredity, they're going to, you're getting these genes from somewhere. Usually there's a family lineage that you can see: gender, race, age, environmental, just what are you exposed to? I live in Boise, Idaho, and there are people, I see patients all the time, and they maybe grew up in California or in Texas, and they get here and they said, I had patients say, I stepped off the plane. I stepped down off the steps in the plane and I sneezed. So every place is different and everybody thinks they have the worst allergies in the world. But if you're allergic to what's there, it's going to seem the worst. Lots of food factors. Lack of introduction is the big one. So having kids that don't get to see these proteins early on, they get hypersensitivity, which we're going to get to that in a minute. So hypersensitivity, it's this undesirable immune reaction, something that's harmless, we think is harmful, and our body responds. And we have these symptoms that make us pretty miserable. Four types, I'm not going to get into that for this talk, but there's four types of hypersensitivity reactions. Most of the ones we talk about are type 1, which is that classic IgE-mediated reaction. And this is it in a nutshell. This is all the biochemistry. This is all the pathophys or physiology you're going to get in this whole slideshow. Our immune system sees a protein that is determined to be negative, an allergen. We make IgE. That IgE then coats mast cells, which are in the tissues in our body. And then when we see that allergen again, we get the dumping of all of chemicals that can make us miserable. So this is what's going on. Kind of, we learned this in school. This is the classic IgE-mediated allergic response. And if this is happening all over the body in a widespread reaction, that could lead to something severe like anaphylaxis. If it's happening in my nose, I get runny nose and I get the little crease there and I'm constantly itching. And that's me. I got it right now, in fact. The mast cells that are behind this, these are the cells that, I mean, there's other things, but these are the main cells that dump histamine. These are going to be in the tissue right around where we need them. So in the tissues of our body and the parts of our body that are exposed to the world, that's where these are going to be found, right? In the eyes, the nose, the GI tract, respiratory, and in the skin. These are the ones that cause the problems. When the mast cells break open, right, they dump lots of things. Histamine is kind of the main mediator. There are other ones, but for the just sake of focusing, this is the one that can make you most miserable. If wherever the histamine gets dumped, if it gets dumped in your nose, you may make more snot or exudate. You might make more in the GI tract, more mucus, mucus and phlegm in the lungs that you cough up, tightness. All of these things are just mediated by this nice chemical mediator called histamine. Tryptase is also a player, and it's just one. And I throw this in there because if it is something that is tested during an allergic reaction, it can be elevated and it can be helpful. So I would just throw out that allergy testing and treatment can be life-changing. And before I got into allergy a long time ago, I had no idea just how miserable people are with these allergies and just how much better they can feel. And so as I go through this, we'll talk about some things that you can treat and how you treat these allergies. But I ask people, what's the burden? If your allergies they're bothersome 10 months out of the year, or for 5 months out of the year, you're just miserable, then there are treatments that can really change your life. If you're miserable for 2 weeks in the summer, okay, treat, that's fine. But just keep in mind, if the burden is high, there is treatment. So we can do skin, if you want to test, if you're considering testing your patients, if your patient wants to know if they can be tested, you can do blood tests and you can do skin tests. Those are the two ways we can check for IgE, all right? And so here's my question. I'll throw this out. When is it a good time to order large tests? Like I'm going to order a food panel with 50 foods, or I'm going to order an environmental panel with 50 environmental allergens. And the best time to order this is, of course, never. Never do it. Please don't do it. Please don't order these ever. Widespread panels do not tell you anything because blood tests cannot diagnose an allergy. They can't. A blood test will tell you if you have IgE to a specific item. So I could test you for 50 foods, and everybody watching this, I promise you, if I tested you for 50 foods, if I had a 50 food panel, you're going to be positive on at least 2 or 3 of them. And it comes back positive for banana. And I say, are you allergic to banana? You're like, no, I eat bananas all the time. Well, you're not allergic. If you have IgE to a food, you're sensitized. That means you do have IgE, but it may not cause symptoms. So food panels and wide panels, they don't help. They just tell you what you might be allergic to. Now, if somebody you think had exposure to banana and it seems like they may have had an allergy to banana and there was a reason and you want to do it to fit, now I'm taking symptoms and I'm testing based on that, based on the presentation of the patient. That's different. The other way is to do skin prick testing. We do these in the allergy office all the time. As long as the patient doesn't have antihistamines in their blood at the time, we can in the tissue. Outdoor, we do trees, weeds, grasses, pollen. Indoor, pets, mold. And so this is what it might look like, where you have a skin test for different, you can see the different foods here. And so this is saying, are you allergic? Do you have an allergic reaction in your skin to these things? I'm not asking if you have IgE. I'm asking, do you have IgE and do you have symptoms? In this case, the redness. This is another test right there you can see on the back. Testing for environmental allergens, things. This will tell me if your reaction. There's some other examples. We can do intradermals. These are a little bit stronger than skin prick testing and can be very helpful. So these are just the ways we can test. And again, if the burden is high, you might want to refer your patient. Patch testing, this is for contact dermatitis. This is for delayed type hypersensitivity reactions, more like type 4 reactions. You put these on the skin, leave them on for a few days, and then you take them off and see if the patient has a reaction. If you get this kind of a spot, so these are the spots, once you pull them off, if it looks like this, you can see if somebody has a reaction to something. And this could be dyes or chemicals or solvents. Patch testing, super helpful. This, very helpful if you think somebody's coming in contact with something. Refer them out. Allergy can test them and tell them if they are allergic to certain items and then how to avoid those items. So very helpful. So if they're positive, if there's tests that are positive, there is a treatment, and I'll say it because I'm currently not doing anything, so I'm not doing any allergy testing or allergy shots, but I will tell you that it's often pretty close to a cure for patients. They get on allergy immunotherapy, they tend to do very, very well, and people that stick with it, cure is maybe a strong word, but I tell them it doesn't always, I mean, it may make your allergies better, but it often makes your allergies gone, kind of like what we get with biologics. So allergy shots, typical plan, weekly for about 6 months to a year, and then biweekly, and then you go to one monthly. That's a typical plan. There's lots of different ones out there. If you do want to do blood testing on patients, you can do a CBC, which may show their eosinophils are elevated, and you can also do a total serum Ig. Sometimes that's helpful. So that's kind of where we're at with allergies and what we're doing in the allergy office. Before I go into the specific treatments in just a second, do want to hit on two groups. Do this very quickly. I'm going to fly through this, but think about two groups. Infants born now with a high likelihood of having a peanut allergy. So kids born and they have a higher risk for developing a life-threatening peanut allergy. And the second group is kids or adults that already have a peanut allergy. Can we do anything about that? So I'm going to just share a couple things. Maybe this is known a little more. I started doing this, trying to, update the education a few years ago. This is more common now. And I don't know, this guy does not need anything. He doesn't need any help. He is perfect the way he is. And we can always get a peanut sniffing dog. Wasn't that great? That's amazing right there. So the first group I'm mentioning, kids with a high likelihood of having a peanut allergy. Can we reduce this risk? And it's, again, getting more common knowledge. But if you're not doing that yet, then I encourage you to start introducing peanut early. And the idea here is that we get sensitized to peanut and then we have a peanut allergy. Prevention of this could change the way we treat this. And so the rates have been going up. They've doubled in the last 10 years. And so can we do something about it? All right. So most kids that get a peanut allergy, they don't outgrow it. I put a little question at the bottom. What % of kids outgrow milk allergy? And it's probably about half, a little more than half still outgrow milk allergy. So that's a good one. But peanut allergy, they don't. So who's at risk? So we're talking about infants born now and they're at high risk. Family history of food allergy plays a role, maybe not quite as strong as we used to think, but there's a role. If they have atopic dermatitis, that's the kids that we worry about. Infants born with eczema, any eczema, but for sure if they have more moderate to severe atopic dermatitis, those are the infants that need to be in this group, that need to be treated. If they have an egg allergy, we wouldn't always know that, but if they did, if they have asthma, these are kids that are higher risk. These are infants that we want to try to prevent peanut allergy, all right? So the way we treat this, again, a little bit more widespread use of this because the guidelines have all been updated, but when infants are exposed to peanut protein early, there's a huge benefit and the prevention of peanut allergy later. When kids were exposed to peanut protein early, there was a huge drop in the amount of kids with a peanut allergy. And in this trial, the early introduction of peanuts significantly reduced the frequency and development of peanut allergy. Ended up with where we're at is about an 80-ish% chance of getting rid or of avoiding a peanut allergy. So infants born, especially those that are high risk, if they are exposed to peanut protein early, their bodies see that protein and recognize it as safe. If it's exposed, and this is through the GI tract, sometimes we know that kids often are exposed through their skin, they get touched or whatever, and they get peanut protein. And when they're exposed to the skin, it's a very different response. And that is not a protein that's seen as safe, and then they can develop an allergy. But when exposed to the GI tract, they do very well. So the guideline update is this: for infants with severe eczema or egg allergy or both, you're going to maybe work with allergy on that, but you really do want to introduce them to peanut containing foods. All other kids in groups 2 or 3 still should be exposed to peanut containing foods early. This is how to prevent peanut allergy. And this is a whole talk on just this subject, but if you can expose them to peanut protein early, you prevent that. How do you do that? This is how, and the preventpeanutallergies.org is a great resource. So I'm just throwing this out there. It's not really a big part of this talk, but you can go a long way to preventing peanut allergy. Again, maybe 80% reduction in overall infants that go on to develop a peanut allergy if they're exposed to peanut early. And that's how to do it. And exposing them is very safe. Severe anaphylaxis in an infant is not that common. So it's a very safe thing to do. Second group is any person that already has it. So if they already have an allergy to peanut or to cashew or there's other nuts, can we treat this like any other allergy? Can we take away the real fear? And the goal here is just to desensitize patients. They have a peanut allergy. If we can slowly build up their tolerance by giving a very small amount and then increasing that over time, getting them to the point where their body tolerates. They can't necessarily eat whatever they want, but they can become desensitized to that thing. Start with a very low dose, and then you can see over time, you just increase the dose, keep going up to the point where they can have maybe up to 2 peanuts at one time and not react. That would be significant desensitization, and it would protect patients from accidental exposure. So in this second group, any person with a known anaphylactic peanut reaction, slowly increase the amount ingested over time, working with an allergist, and get to the point where accidental exposure, you eat something that has some peanut in it and you don't react. Instead of being life-threatening, it's nothing. So this is amazing. There is a medication. I don't have any conflicts. I don't work for this company at all, but there is a medication called Palforzia where the peanut protein is slowly increased, and this is done to desensitize patients. And it's pretty effective. So I just want you to know this is out there, all right? So for high-risk infants, they need to have peanut introduced early, but really all infants should have these proteins introduced early so that they don't become allergic later. And then anybody older that already has it can be desensitized. So those are a couple of new things. How am I doing on time? But I want to try and talk about treatment. So let's get into just the seasonal allergies and things you can tell your patients. I'm going to go through the areas of the body and just talk about how we can treat those different areas. So pink eye, right? Pink eye is more bacterial, viral. This case, it's pink eyes from allergies. So allergic conjunctivitis, miserable, right? Some tricks. Oral antihistamines, which are a great basis for a lot of allergies. Oral antihistamines and nasal sprays don't really do much for the eyes, all right? So if you're dealing with itchy eyes, allergy eyes, generally you need a drop. So Pataday or olopatadine is great. It is over the counter, so you can get it that way or prescription. There's a couple of different formulations of this. There's some that are twice a day, some that are once a day. The tip I would give is tell patients to keep them in the fridge. They feel really good, and the expiration date goes out much longer. They're good for about 3 years in the fridge. And these are very, very good. All right. So if somebody has allergic conjunctivitis, they have itchy eyes, they can use Pataday, and you can use this as needed. This isn't something you have to use daily. There's another drop called Zatador, a little bit more of a mast cell stabilizer, although Pataday does that to a degree too. So allergic conjunctivitis, use eye drops, and that will get at it in any form. This is just a little bit more severe. Look under the lid. Tip is just to look. If they have allergic conjunctivitis that goes on over time, then you're going to get these papillae inside. And this is just a much more severe. This patient is going to need a little bit more therapy. We would try to figure out what they're allergic to and do some avoidance or do allergy shots, but also probably use some steroids on that eye. Just look to see if they need something else, and maybe you're not comfortable treating that, but if not, you can certainly get them to somebody that does. Okay, so look under the eyelid, see how bad it is, treat them. What about the nose? All right, so we've got the nose. The job of the nose is to warm and humidify air. That's the goal. And when those turbinates get swollen, they get boggy and bluish coloration, and they make a lot of snot, and all of a sudden we're miserable. So the base therapy that you start with allergic rhinitis, if you're trying to treat it, right? If they're really miserable, getting them to an allergist, doing skin testing like I showed you. If not, if they are miserable and you need something, all right, then antihistamines are the way to go. Sedating are okay. I said they're good, and I should change it. Okay. So the first generation have anticholinergic properties. And so they are, diphenhydramine is the one we use most, Benadryl. Generally, we don't use this a lot anymore. But if you're going to give something that's like this, then give it at night. It's a short acting and it's not super effective. So try to steer away from these. But those are the first generation that are sedating. The much better way to go is the second generation non-sedating. So allergic rhinitis, going to go at it with oral therapy first. I mean, there's nasal sprays I'll show you in just a second. So Zyrtec is cetirizine. It's the best antihistamine. It's what we go to. It's what I like to use. And 10 milligrams is fine for mild allergies, QD. But if they're struggling, don't hesitate to go to twice a day. So twice a day Zyrtec, they can do 2 in the morning or 2 at night. Is great. If they're going to do loratadine, it's the same dosing. Allegra is great. I mean, there's some benefits to Allegra. Is it's the least sedating, most likely to cause nothing. Most people don't have any symptoms. If you're going to use Allegra, I usually start them out at 2 a day or 360 milligrams. So Zyrtec is great. Claritin is fine. QD dosing, move them to BID if needed. I have patients that do 1 Zyrtec in the morning, Claritin at night. There's no data, but they love that and it thinks it works. So okay to mix and match. Okay to take BID. These are much better when done daily. Eye drops seem to be fine to do as needed. So if you're miserable, use them. You can certainly use them every day. And if it's in season and you're miserable, I would. But seems to work as you do PRN. 4 oral antihistamines. The key to patients, take the right dose, which for most people is not 10 milligrams, but 20 milligrams a day, and take them daily. Stick with them, get tissue saturation, get them in the body so that when you're exposed, the histamine cannot make you as miserable. And this is also the case for chronic urticaria or if they've got skin issues, you can do these antihistamines. I'm going to show you another thing in just a second about skin. All right, so a couple other things with allergic rhinitis. Nasal steroids work great. They all work great daily or twice a day. The opposite hand technique is important. So right hand to left nostril, left to right. So if they're using Flonase or if they're using Rhinocort, any one of the nasal sprays, I just would encourage them just kind of to make sure they're not hitting the septum. If they do, they'll get sores and that plexus can bleed. So right hand to left nostril, left hand to right nostril. Make sure you're not hitting the septum. And then this is the target tissue. If you think about where the tissue is, it's right there. It's not up and the olfactory bulb or towards the frontal sinus. So you really want it to come into the nose that way. So I don't, people hold it really level and really point it up, and you want to bring it down a little bit more level so that it gets to the target tissue. Do the spray and just let it go. It doesn't need to, you don't need to inhale. So use the opposite hand technique once a day or twice a day. And this can be very helpful. So allergic rhinitis, we've got oral, we've got Zyrtec or Claritin or Allegra, once a day or twice a day. Use it daily. If you're doing a nasal spray, they can work very well. You can get it at this is Costco, and it's available on Amazon, very inexpensive. If somebody doesn't like the spray, the smell, I can't use Flonase. It drives me crazy. It's just the flowery smell drives me crazy. It goes down to my throat. Flonase Sensimus doesn't do that. So it's a very nice product, and you can get a 3-pack at Costco. For allergic rhinitis, if they want to do any rinsing, that's great as well. This is the NellyMed kit. If you call the company, they will send you samples. They'll send you a big box of bottles and sinus rinse. This is how to make your own. So there is this is a good recipe for making their own, and you can make this and do irrigation at home. That works pretty well. I call it waterboarding for allergies, but if you can do it, it does help. Another tips for this is you can put prescription budesonide in there. So if you're not familiar, you can call any pharmacy that makes this, and they can compound some budesonide for you and use that as nasal irrigation. So you're irrigating with the steroid in the water. I put adding mupirocin ointment. I don't know. It seems to be, people seem to like it. So I'll have them squirt some mupirocin ointment in there, mix it up, and then irrigate with that to kind of leave behind a film of antibiotic and keep the colonization down. No data. At least if there's data, I haven't seen it. I don't know of any data, but I've had patients love it. They say it makes all the difference. I don't know. I don't know if it's all psychosomatic or placebo, but they seem to like it and it doesn't really cost anything. And then I just put another tip, ipratropium bromide nasal. If you're not familiar, put this down, stop the video, write it down. It used to be called Atrovent nasal. It's ipratropium bromide, very potent drying agent. So it's not an anti-inflammatory. It's not Flonase. It's not a nasal steroid. It is a strong anticholinergic snot stopper. So if people have runny nose that's clear, that's maybe not allergic, maybe it's a cholinergic or vasomotor rhinitis, that is inexpensive and very effective. So anyway, that's just another tip if you're not familiar with that. I just put that Zyrtec is very cheap. In fact, this is an old slide. It's I saw it at Costco last week, was $12 for a bottle of 365 Zyrtec. So get it there. Allegra is always a little more expensive, but still at Costco or on Amazon, get the big bottle and it's very inexpensive compared to other options. All right. So one thing on urticaria, I just want to point out, there's a term histamine blockade. We're not really blockading, but it's a way to think about it. And this is what I'll do routinely. And I get it. This is probably the most common question I get asked is, what do I do for urticaria? Zyrtec twice a day. One of the H2s, ranitidine or cimetidine. I know some of them are off the market for packaging reasons or whatever. So use one of those. And if they're miserable, I'll sometimes do oral prednisone. But if not, you can just get by with a twice a day H1 and a twice a day H2. So Zyrtec twice a day, ranitidine twice a day works really well. And most patients, by the second day, their symptoms are under control. So you can use this for urticaria that they know the cause. Maybe they get it every year in grass season or whatever. They go for hikes and they get them. Or if this is just acute urticaria without a cause, it's just idiopathic. Using the Zyrtec and then the H2 twice a day can be really helpful. All right, so that's just a list of some facts that you can get, and that's a good foodallergyawareness.org is a good option. FAIR is the Food Allergy Research and Education group. They're the best online group for food allergy information. So if you need information, you can go to foodallergy.org. They have a lot of good tips. Also, resource for clinicians, just if you need some additional stuff, those are good resources out there. So anyway, when it comes to allergies, that's antihistamines, oral and nasal sprays work good, and use eye drops for the eye. But if the patient's burden is high, if they're miserable more than a few weeks of year, or they've had it, they don't like to take medicines, or no matter what they take, they get groggy or sedated with them, get them to an allergist, because you can test, and the allergy treatments are amazing. They really do work well. It's not just, it's a big commitment, but it works well. Okay. Last couple of slides. This is in the allergy realm, but it's a little bit different. But if you're out there and you see patients with anaphylaxis, I want you to know there's an option now to treat anaphylaxis without a needle. And so this is Neffy. It's a nasal spray. Actually, I have one right here. It's a nasal spray epinephrine. And it is a way to deliver an epinephrine dose with a nasal spray, and works very well, very similar to epinephrine auto-injectors in that it's provided when, if there's an anaphylactic event, this is provided. It's a single dose. If you're curious, I don't work for them. I'm not promoting them, but this is the data if you want to see that right there. And Neffy is if you've seen maybe Narcan before, very similar. The packaging and the way it's delivered is exactly the same. They use similar technology to getting medications in with Intravale, which just helps it get absorbed. So it's epinephrine. Think of it like an EpiPen without a needle, that is done a single spray into the nostril, and the dose given is very similar to what you would get from an IM or sub-Q epinephrine dose with an injector, all right, or with a needle and syringe, but no needle. The scary part is gone. This is it's a game changer because you take away so much of the fear. It's small, little portable packaging. If you're curious a little more about some of the details, its shelf life is longer than epinephrine, and it has a little bit better storage temperature range, so it doesn't go bad as easy. It's smaller, easy to carry, And overall, just a really great way to have patients who have anaphylaxis and need epinephrine to do this. And there's some instructions on how to use it if you want to look that up. And I can certainly get you information from the company. Again, I don't work for them, but I get samples from them, and would be happy to connect you with anybody if you don't know who the rep is or you haven't heard from them. So anyway, that's what I have. That's how to treat allergies and a little bit about where we're at in the allergy world. That's my name and contact information. Again, reach out if I can ever be of assistance. Thanks for watching.